and now we'll go into detail about handling each type of reconstruction of the eyelid, starting with Dr. Akshay Nair, who's a prominent oculoplastic surgeon practicing in Mumbai, India. And he'll be talking about managing upper and lower eyelid retraction, which is a difficult scenario for many oculoplastic surgeons to handle, and there are various ways to handle it. So we'll get some insight from him on that.
Thank you so much, and I noticed how the previous speaker spoke about harvesting mucous membrane grafts, hard palate grafts, all of which is amazing because that covers a lot of the surgical technique of what I'll be talking about in terms of. Okay, a second. Yeah. So lid retraction. So I've divided this broadly into two topics: upper lid retraction and lower lid retraction. There can be many causes of upper lid retraction, and the most common, of course, being thyroid eye disease. Pseudoproptosis or proptosis can also give the appearance of lid retraction purely by the physical outward projection of the the eyeball that gives the illusion of lid retraction. Post-surgery can be another cause where, because of surgical correction to the superior rectus, the ptosis overcorrection, and rarely myasthenia, paradoxically, and hepatic failure are systemic causes. We'll come to contralateral ptosis as a cause of proptosis or pseudoproptosis in the other eye. So enlargement of the globe, especially in axial myopia, unilateral axial myopia, or true proptosis by outward protrusion of the globe because of a retrobulbar mass, pushes the upper lid up and is also associated with lower lid retraction. So in cases where you're unsure or you feel that there's some amount of proptosis, it's always a good idea to get an exophthalmometry done. Now, thyroid eye disease lid retraction is commonly associated with the classical lateral flare. Now, in this patient, you can see that in the left eye, you have a more typical lateral flare. The lid retraction is clinically visible by the scleral show that you see superiorly, where typically the lid should rest 1.5 to 2 millimeters below the upper limbus, but here instead it is resting 2 millimeters above the limbus. The lateral flare occurs because in thyroid eye disease there is initial scarring of the fascia between the lacrimal gland and the levator muscle, which is present superolaterally, causing a superolateral lift in the eyelid, giving it the classical flare. Whenever you see a patient with thyroid eye disease, it's important to work up and assess the endocrinological status of the patient. So get a free T3, T4 TSH done, as well as thyroid receptor antibodies to understand what phase of thyroid eye disease that patient is in, because that will also help you decide what other treatment needs to be done. If it is an active disease, and the patient has an active clinical score of more than 4, you should actually go ahead and treat the patient with immunosuppression to correct the orbital and the eyelid component inflammatory phase of thyroid eye disease, as well as address the symptoms in terms of lubricating drops and other methodologies to address the surface-related issues. And finally, deciding when to operate. You can either operate it once it is in the burnt out or in the inactive phase, or you can plan it later on when if there are other surgeries like decompression needed. I prefer to treat thyroid eyelid retraction in the inactive phase or the burnt out phase. Rarely in the active phase, if a patient presents with isolated lid retraction, you can also go in and treat it with injections. So this is not a hard and fast kind of a rule. This is more of what I follow. If it is mild eyelid upper eyelid retraction, an intralevator steroid, either with triamcinolone acetonide, 5-FU, or additionally using 5-FU and botulinum toxin can be given. Now, mild is where the upper eyelid rests at the limbus, as you can see in the top picture. Moderate would be where it is about 2 millimeters above, and severe would be where it is more than 2 millimeters above the upper limbus. In moderate, one can either do a muellerectomy or a full thickness blepharotomy, and in severe thyroid retraction, you can do a complete blepharotomy with or without a spacer graft to be placed to increase the width of the length of the posterior lamella. So now in upper eyelid mild thyroid related retraction, I like to give an intralevator or subconjunctival steroid injection, which is mainly given at 2 points. 0.5 ml along with is injected in 2 aliquots at the mid-pupillary line and lateral to address the lateral flare if there is any. You place in a Demar retractor, flip the upper eyelid. It can be a little difficult in patients who have thyroid eye disease because of the tone of the Mueller's. Put in a drop of paracaine and under topical anesthesia just above the tarsal edge. You go in subconjunctivally and inject into the Mueller's and the levator muscle. It works by 2 ways. In active disease, the steroid reduces the inflammation and the overactivity of the Mueller's muscle. And additionally, by stretching out the conjunctiva and the Mueller's and the levator and the attachment to the tarsus, it physically and mechanically stretches it. Now, in burnt out disease or in inactive disease, adding a little 5-FU helps to modulate the levator stretch that there is, the scarring that has set in, and can help in releasing well. It, of course, in burnt out cases, you may need more than 2 or 3 injections as well. So in moderate upper eyelid, I also again prefer the same technique. Only thing here is that I like to add about just 1 unit of botulinum toxin, which adds to the neurogenic component of bringing the eyelid down. And once it is down, the stretch effect of the depot steroid that you've injected acts for a little longer. Only thing is that in moderate disease, again, like burnt out lid retraction, takes 2 or 3 injections, and I prefer to add 5-FU in all these cases. So it's 0.5 cc of triamcinolone and 0.5 cc of 5-FU, and then inject 0.5 cc of this mixture. And finally, in severe thyroid eye disease related retraction, I can do a Muellerectomy or full thickness blepharotomy, which can be graded based on the severity. The full thickness includes an incision through the lid skin, the orbicularis, and at the upper edge of the tarsus, separating the attachment of the levator or the Mueller's with the tarsus, and creating an open space where one could even add a spacer graft, and done under local anesthesia. There are many papers that have shown this to be a very predictable technique. This is how I like to infiltrate. This is a picture of a case which was operated by Dr. Milind Naik at LV Prasad. This is dissection done subcutaneous through the orbicularis, isolating the tarsus. That structure that you see here is the tarsus, above which is the Mueller's, and you can see the radiofrequency cautery tip has begun creating a full thickness blepharotomy. Now the blepharotomy is continued till there is just a small central attachment, and the lateral horn should be disinserted, especially to address this lateral flare. Check intraoperatively the amount of correction that you want. Over correction with the lid 2 millimeters or 3 millimeters below the limbus is ideal, because believe me, even after a full thickness blepharotomy with no attachment to the tarsus, the tone of the Mueller's and the levator is so much that it brings up the eyelid even in those cases. No suturing the conjunctiva, but definitely suturing the orbicularis back and the skin back in continuous. And these patients do really well. This is a patient who had both eyelid retraction, upper eyelid retraction surgery done with a blepharotomy. And you can see that even the eyelid scars have healed well. Again, another patient, bilaterally done, operated. This is a unilateral case. The only case that in some cases the pre-tarsal show may not be ideal and matching, and you may need to do a subsequent surgery to get a symmetry of the lid crease. So this upper lid surgery can also be done in combination with thyroid surgeries, where it can be combined with a lid crease incision when you're doing a decompression. However, lid position may not be predictable, as it can come down because of the decompression of the orbit, so it can also be staged. Lower lid retractor release can be done at the time of decompression. So now that takes care of upper eyelid retraction. I'll come to lower eyelid retraction. Now lower eyelid retraction, cicatricial ectropion because of scarring of the anterior lamella are on the same continuum, but I'll not be speaking about cicatricial ectropion, which in itself is a separate topic. I'm going to talk more about lid retraction because of posterior lamellar or middle lamellar related issues. Now lid retraction in the lower lid can either be age related, which is very subtle and due to gravity, or it can be post-surgery, typically surgeries that violate the lower lid retractors, like a blepharoplasty or a fracture release. And it can also be post-trauma and post-thyroid eye disease, like we already know. It's a little bit important to know the three lamella, the posterior lamella, which is the tarsus, the lower lid retractors, and the conjunctiva, and the anterior lamella, which we know is the skin and the orbicularis. The middle layer, or the middle lamella, which is now more like a functional rather than a structural entity, is the orbital fat and the septum. And adding volume here is a very, very good important part. One thing to do whenever you see a patient with lower eyelid retraction is to do a forced eyelid traction test, where you take your fingers, place it at the edge of the lower eyelid, and pull it up to see how far up it goes. Now, ideally, your finger should be able to reach the upper lid margin and completely close the eye. You can actually try it yourself. But if you feel any kind of limitation, that gives you that this is a positive forced eyelid traction test, and there is a posterior lamellar contracture that needs to be addressed. Now, age-related lid laxity and canthal laxity can also cause some change here. You can see in the left eye especially that the lower lid had descended down and you have a little inferior scleral show. This can be addressed by a simple lateral canthal tightening. I just have 6 more slides. I'll complete that. Post-surgery, especially post-blepharoplasty, post-fracture repair, orbital surgery, these cases can have lid retraction, and either too much of the fat or the septum has been violated, causing it. So this was a patient who had middle lamellar scarring. Now, on the face of it, it may appear that skin graft is needed, but actually a skin graft was not needed because skin was not actually excised. So what was done was lower lid filler was given, and with the filler, the stretch effect, the middle lamella was augmented with volume, and that gave a good correction. Now again, this is a patient who had a trauma. You can see the lower eyelid, there's a fracture, there's a titanium mesh placed, which has caused the scarring of the posterior lamella, leading to eyelid retraction. Again, a tear trough hollow with a little filler in the lower lid, although I think he could do with a little more filler, and that has helped to bring up the lower lid retraction. Post-blepharoplasty, this is asymmetrical lid retraction, and a hard palate graft was placed. Look at the right eye, the lower lid is 2 millimeters below the limbus in the right eye, and we added a hard palate graft. The place to add the hard palate graft is at the lower border of the tarsus, which is then reattached to the lower lid retractors or the orbital, the capsulopalpebral fascia. Another case, this is a patient who had significantly more scarring after a cheek implant, which was done outside. And the patient came back and had this kind of a picture. He said his eyes were appearing droopy, so a hard palate graft was put. Some patients, they come to you with no surgery, no trauma, no thyroid eye disease, and they just say that they want the eyelid has gone down and they need it to be done. So that's what we call a cosmetic lower lid retraction. You can augment these cases with a canthopexy. This patient actually had an upper eyelid blepharoplasty, has lid crease asymmetry, but wants this lower retraction to go. Sometimes you wonder and look at the patient and say, what lower lid retraction? It's hardly visible, but it's there. That's the lower lid retraction, 2 millimeters. In these cases, all you need to do is an isolated lower lid retractor release with an upper lid frost suture, lower lid frost suture for a week that stretches out the posterior lamina and corrects it. Thyroid eye disease lower lid retractor, isolated lid retraction without proptosis can be corrected again with a lower lid retractor release along with an extreme lateral tarso or a canthoplasty. You can also address the upper lid at the same time. My last slide, this is a patient who came to me, had ptosis, and this was the picture, and another surgeon in a different city had advised levator resection with canthopexy. Now, the reason why this patient has apparent lower lid retraction is because of the ptosis. The mechanism here is that because of the ptosis, the there is an inherent drive to lift the upper lid. The upper lid is lifted by the levator, and apart from the active lift on the levator, the patient also has an inactive or a passive reduced tone of orbicularis, because the orbicularis is the muscle that closes the eye. So when the levator is trying to lift, the opposing muscle orbicularis also loses its tone and reduces its activity, and therefore there is the apparent lower lid retraction. He underwent a ptosis surgery, and After the ptosis surgery, the lower lid automatically comes back into position and is symmetrical. So to summarize, lower lid retraction can have many causes. It's important to identify and address the cause based on the severity. Do not forget the canthus while addressing the lower lid, especially in older patients. Fillers and scar modulators, by adding volume to the middle lamella, can buy you time or even treat the actual cause. Timing is important in thyroid eye disease, because you need to make sure that you do not operate when it is active or end up having more complications. Thank you so much.
Thank you, Dr. Akshay. That was a very comprehensive coverage of the topic. I think it's interesting that you said that lower lid fillers can buy time, because we had a similar patient who had a surgery done for squint inferior rectus surgery, after which she developed some amount of lower lid retraction, and she had some pre-existing mild ptosis as well. So the checking for the tightness of the lower lid is again important. So there was a little bit of tightness, so we had to put in a filler temporarily for an event for her. But later on, we had to go in and do a hard palate graft to definitively correct it. So, anything else that anyone wants to add?
Sure. Thank you.
So when we talk about upper lid retraction and TLD, blepharotomy, yes, it's a So would you prefer blepharotomy or the LPS recession as a surgical modality for the upper lid retraction?
So I think they just they pretty much go hand in hand, except that in an LPS recession, you actually have to open up the septum to reach the levator. And yeah, I think, at the end of the day, by disinserting the Mueller's and the conjunctival attachment on the tarsus, obviously the levator is also being disinserted. But yes, in a recession, you actually go up and displace the levator further up. So I think in those cases, in the more severe they are, I may have to add a levator resection. But now over time, I find that levator recession is a little less predictable in my hands. So I either prefer a blepharotomy or a blepharotomy with a spacer.